נשוחח היום עם פרופסור ננסי וודס, דיקן בית הספר לסיעוד של אוניברסיטת וושינגטון בסיאטל, וושינגטון. בית הספר לסיעוד של אוניברסיטת וושינגטון הוא בית הספר המוביל בחקר הסיעוד בארצות הברית ובעולם כולו. פרופסור וודס נמצאת כאן בישראל לשם קבלת תואר דוקטור כבוד מטעם אוניברסיטת חיפה על מחקריה הענפים ותרומתה המשמעותית לחקר בריאות האישה. פרופסור וודס ידועה בשל מחקריה פורצי הדרך שהתמקדו בהשפעתם של היבטים פיזיולוגיים, הורמונליים, כמו גם נפשיים וסביבתיים, על טיפול בנשים לאורך כל מעגל החיים. מחקרים אלה התוו עקרונות שקובעים היום קווים מנחים לטיפול וקבלת החלטות טיפוליות בנשים. פרופסור וודס פרסמה יותר מ100 מאמרים בכתבי עת מובילים ברפואה ובסיעוד, וכתבה או ערכה 18 ספרים שמשמשים כבסיס לחקר לימודי האישה. Hello, Professor Woods.
Hello, shalom.
Shalom. I'm honored and grateful for this opportunity to have this discussion with you.
As am I.
Thank you. And I would like to first ask you, if you will describe to us the personal and professional journey that you have gone through until this point that you have reached your esteemed position.
That could take a long while because I'm nearly 60 years old and I've spent a lot of my life in an academic setting now, but I'll give you the short version.
Okay.
I found myself in a nursing program as an undergraduate, having started out as a musician, but wanting desperately to do something that was socially relevant during the 60s in the US. And as a consequence of my early nursing experience, I found that women's healthcare needs weren't being very well met. One of the first people that I cared for was a woman who had been beaten by her husband and who, after 6 months of rehabilitation, left the hospital not only with her parents, but in the company of her husband. And I remembered as a very young nurse standing at the end of the hallway wondering, how did we let this happen? How have we invested 6 months in rehabilitation directed at helping this woman return to having as normal a life as was possible, only to send her back into the same social and family circumstances that might cause her to not only be beaten again, but perhaps killed even as a consequence of the marital conflict that was in the family. That experience led me to think more critically about what I read and what I was learning about women's health as it was written in traditional English reports of research. I found often that there would be descriptions of women's experiences after their breast cancer experience that suggested it was largely a sexual assault on them. And then in doing research with the same women and in clinical practice with the same women, had them tell me that that was really not highest on their list of concerns. They had existential concerns. Would they live? Would they die? Would they survive long enough to see their children graduate from high school or college? Would they survive to see their children marry? So the things that were most pressing to them were not really about how their bodies would look as much as would they survive. I began to wonder what the filters were that were being applied to the thinking about women in their health and health care. And that is one of the things that really led me to be convinced of the necessity of doing work to provide a different point of view, a woman-centered point of view about women's health and our health care. So
would you describe, please, the major steps in your career as a nurse and as a researcher, your various points along the way?
Thank you. My experiences as a nurse were profound in that the early exposure that I had to understanding the human experience of dealing with health problems or with learning to live with a disease such as diabetes had a profound impact on my thinking. I think it really helped me appreciate the challenges that people faced in response to an illness, and then also sometimes the challenges people face with respect to staying healthy. The focus on recovery initially helped me to appreciate that it was not just a matter of a health problem that a diagnosed individual experience, so a woman or a man, but often that those problems became problems for the family, not just the healthcare system. So what we were doing by way of caring for people in the U.S. Remains still very individually directed, without as much appreciation of the fact that illness is a family experience as we might appreciate. And that also has a great deal of relevance to women's health, in that often women are the ones responsible for family caregiving, for taking care of the family members who are sick, but also for often providing the extra care that is needed by children and older adult family members. So that clinical grounding in the range of problems that women were addressing and the experience that people were having in caring for family members was very important. I had a great opportunity to work as a nurse providing follow-up care after people left the hospital. And this taught me a great deal about the assumptions that we make about how people will continue with the regimens that we might develop for them and with them while they're patients in hospitals. The resources in families' homes often didn't match the resources that we could bring to bear in situations in a hospital or a clinic setting. And needing to rethink how family members would be cared for at home became a great challenge. I think that was another profound experience that allowed me to see the great responsibilities that women bore in our society for caring for family members. My academic approach was one that began with a Bachelor's of Science in Nursing. And following that program, I found that I was really challenged by thinking about research that could help improve the way that we deliver services to people. So in 1968, I attended the University of Washington in Seattle to earn a master's degree in nursing. And in that program, got my first taste of what it meant to take on a research project that would help me understand better how to provide care for patients. I did a project that stretched me a bit to learn about a new field. I had been working in hospital-based care in what it would now be called an intensive care area, and had the opportunity to study the sleep patterns that people establish as they go through a life-threatening surgery. I studied people who had had open heart surgery, and I discovered, not surprisingly, that they didn't sleep very much when they were in the hospital, and began to look at why that was, and was able to identify that there were some strategies in how we delivered care in intensive care units that were not very caring. They were not very focused on promoting sleep and rest in people who just had a major surgery. What I discovered was that 24 hours a day, the level of light in the intensive care unit was rather stable. It was very difficult to tell whether it was day or night by virtue of the way that the units were lighted. The noise levels were relatively high, and later I followed up doing some noise studies just to see how high, and they were actually at the level of 80 and 90 decibels, which is pretty a high level of industrial noise. So some of the results of that work led us to change the ways in which we provided services to people. We tended to start grouping the activities so that we didn't wake people up every 15 or 20 minutes, and instead tried to allow them to complete a complete sleep cycle. And it was that experience that prompted me to think more about the research activities that nurses could engage in. I found myself drawn increasingly to graduate work, and about the same time that I was contemplating a PhD, I was beginning to be more and more conscious of the need for work focusing on women.
And your PhD, could you tell us about your research and, I guess from that point on,
Yes.
your continued research in the field of women's health?
Sure. At the time I was contemplating doctoral studies in the United States in the mid-70s, there were only a very few doctoral programs in nursing. It was a very new phenomenon. And because I was not physically near a program, I chose to study for my degree in public health and earned a PhD in epidemiology. For that program, my research focused on the consequences of the changes in women's roles in the U.S. at that time for their health. One of the things I looked at was, as many people were studying the consequences of women's employment on their children or their husbands, I asked the question, well, what are the consequences of women's changing roles on the health of women themselves? And thought that it was important that we address that as well. What I discovered was, in interviewing nearly 150 women about their experiences, was that it didn't much matter the kind of work women were doing. It didn't matter the amount of money that they were earning, as much as women who were in relationships and who had a supportive partner or spouse were the women who had far and away the best mental health. So we talked about, well, was that because there was extra instrumental support? Was there somebody in the home that helped share the activities of daily living, things as mundane as taking out the trash or helping with childcare? And it turned out that the women who had the most support at home were the women who had, by and large, the most positive mental health. And actually, they had fewer physical symptoms as well. So that led me to really think about the importance of the social environment as it related to women's health, and our ability to do what we're all doing now worldwide, and that is juggling multiple responsibilities, juggling responsibilities for our children, engaging deeply in professions or in other occupational activities, not only because of our professional aspirations, but because of economic necessity to support our families. And I think as a consequence of the early work looking at women's health and women's work, we were able to say that the social structural supports for women were rather limited. But what happened at home to compensate for that was extremely important.
And your research in the area of women's, I guess, reproductive cycle has stemmed from this original or basic work that you did in your first, I guess, doctorate level research.
Yes. At the time that I was finishing my dissertation research, I had spent a great deal of energy understanding not only the social elements of stress, but the physical or biological elements of stress response, and increasingly saw that the biology, our biology, was very connected to the social environments in which we were living our lives. And I really wanted to understand that more deeply for women, and was influenced by a meeting I attended instead of writing my dissertation. Chose to go to one of the very first meetings of the Society for Menstrual Cycle Research. And this was a fascinating group. The Society brought together people ranging from traditional researchers to social activists with a great deal of interchange. It was one of the most fascinating meetings I'd ever attended. And it became very clear to me that there were some hotly contested theories about the effects of women's menstrual cycles on their health. And having studied stress for my dissertation research, and having realized that the stress axis, the connections between the hypothalamus, the pituitary, the adrenal gland, and then also the sympathetic nervous system response to stress, also modulated reproduction. So in effect, during times of great stress or famine, we have the capacity to shut down our ability to reproduce. given that the timing may be bad. Women who exercise and are elite athletes, for example, oars women, know that during extreme periods of training, they stop their menses. So I began to think more and more about the importance of accounting for the menstrual cycle, a uniquely feminine or uniquely woman-experienced part of our human being, and began to think about the relationship between the menstrual cycle, stress response, and health outcomes. And at the time that I was starting that work, there were a number of debates raging about premenstrual syndrome. For example, was it a psychiatric diagnosis? Was it tantamount to a defense for crime? And as I dug more deeply into the body of research on which some of these claims were based, I discovered that the work wasn't well done. And in fact, often the work focused only on people who were seeking psychiatric help. So I resolved that one of the next steps would be taking a broader look at the symptoms women experienced in conjunction with their menses. So a group of us in North Carolina and then later in Seattle did some of the very earliest prevalence studies where instead of studying women who came as patients to get help or health care, we studied a cross-section of the population and went out and interviewed women about their symptoms, but also gave them diaries that they kept every day for 1 or 2 menstrual cycles, and had them record not only what was happening with their symptoms, but also had them record what was going on in their lives. Again, believing that we can only understand women's health if we understand the context for their daily lives. One of the most interesting responses from that work was that we were able to determine that a relatively small proportion of women, less than 10%, experienced acute changes in symptoms across the menstrual cycle. But nonetheless, we thought that that was an important focus for further work. And we eventually were able to show that both reproductive hormones and both the indicators of stress response, cortisol and catecholamines, were related to the symptoms women experienced. We didn't ever find that there was a huge difference in the level of either estrogen or progesterone in women who had premenstrual syndrome, but instead they seemed to respond differently to changes in their hormonal cycles. So women who had no symptoms had the same levels of hormones and had the same changes, but the women who had premenstrual syndrome had a different response, became very symptomatic sometimes in response to changes in the level of estrogen and progesterone. And also, these same women had symptoms that were related to cortisol levels as well. So that, again, opened the door to think more broadly about, well, what would be some of the ways in which women might be helped to cope with their symptoms? Was the therapeutic alternative really about changing their hormone levels, or was the therapeutic alternative about helping women address some of the challenges in their lives? And our group, our collaborative group, included a woman by the name of Diana Taylor from the University of California at San Francisco. And she did what I consider the best study published to date, looking at ways in which a self-management approach for women could help them learn to live with and to actually experience less severe symptoms in conjunction with their menstrual cycles. So that was a very long process, begun in the late 70s and continuing almost until 1990, as we did a series of studies that helped us uncover the explanations for why women were experiencing these symptoms and how they might be able to best deal with them.
This is fascinating. I think it exemplifies the way nursing science builds on several disciplines, and you give example from fields of physiology, hormonal changes in the human body, and then the social aspect, behavior change, and so forth.
Yes, one of the things that that is probably unusual about our series of studies is that we haven't focused only on a woman's biology or only about the social milieu or context in which she lives her life, but we have attempted to take an integrative view of human health, and that holistic focus on human health is probably one of the best trademarks of nursing science, in that as nurses, in the delivery of health care to people, we are constantly thinking about not only the biology, the physiology, the pathophysiology, but we're also thinking about what is this person's experience? What is the lived experience of having this health problem? What is the therapeutic approach or clinical therapeutics that would help the individual and the family often in their ability to adapt to a new illness or adapt to some of the normal life experiences in which we come into contact with the healthcare system. For example, birth of a new child.
And is this kind of line of integrative thinking, assuming, has also led you in your more recent studies? Could you tell us a little bit more about that?
Well, the more recent work that I have done has been in collaboration with the same research team, Dr. Ellen Mitchell, who has been a colleague of mine now for 25 years at the least. She and I have followed a cohort of women in the Seattle area for the last 15 years. And this is indeed a labor of love on the part of the women themselves, and I think also on the part of the investigators. We found ourselves being asked more and more about questions related to menopause. And as Ellen and I acquired more gray hair ourselves, these questions seemed to be of greater significance to us. So in 1990, we received support from the National Institutes of Health in the U.S., which has a National Institute for Nursing Research that funds studies of nursing science. This work allowed us to focus on, first of all, studying over 500 women in the Seattle area to understand a bit more about the challenges they were facing as they reached midlife. So we initially began studying women between 35 and 55 years of age. We continued that work and have continued that work with a subset of the women for the last 15 years. And over the course of that time, we have been able to identify that women go through stages, as it were, as they approach the menopausal transition. And one of the things that has been very helpful about our work over the years is that as we learn more, we invite women to come to presentations about the results of the study. And now we use a web page as a tool for helping women who use the internet to learn more about the study results. As a consequence of engaging the women in helping us think about the study, we always ask them, are there some questions that you have that we haven't asked you? You know, what are the questions that you think are most important for us to be trying to answer with the study? And one of the things that women kept asking us was, how will I know when I'm done with this? How will I know when I'm just about at the time of my last menses? Is there anything I can do? Can I have a test to predict this?